forward, okay? Now, if you give someone heparin, does that dissolve the clot? No. What dissolves the clot? TPA, something like TPA. Please understand the difference, okay? Please understand the difference. Now, are all people that are laying in the bed in the ICU, are they all at risk for DVTs? Yes, perfect. And do you understand the interventions that you would do to prevent that? SCDs, maybe some sort of anticoagulant, yes. Maybe if you were able to get them up and moving, you would have them walking, right? We know that everyone is at risk for that. And in the same turn, if they're at risk for DVTs, they're also at risk for PEs, right? What is something that we can do that is the first line when talking about atelectasis? What's the first thing that we can do to help people prevent that?
Ambulate.
Okay, you could ambulate, sure. Incentive spirometer, okay, incentive spirometer. Incentive spirometer is something that we should all be familiar with that can help prevent atelectasis, okay? We often call it pulmonary toilet, yes.
Between ambulation and the
Incentive spirometer. Yeah, incentive spirometer, okay? Incentive spirometer coupled with when you encourage people to cough and deep breathe, okay? Why? We want to pop open those alveoli, okay? We want to pop open those alveoli. Incentive spirometer is your first line to treating atelectasis, okay? Treating atelectasis. Please review paralytics when you would use them, okay? What kinds of things you need to make sure that you're thinking about. The difference between non-invasive ventilation and invasive ventilation, so BiPAP versus mechanical ventilation, okay? All the things that we talked about, VAP, ventilator-associated pneumonia, or VAE, ventilator-associated event, okay? Yeah.
For paralytics, do we just re-study the ones we did for module, for the cardiac, for the FAR module?
Yes. There's no new ones that I would introduce. Really, I mean, it's not necessarily the name of them, but what you do, like what kinds of things you need to be on the lookout for if you're on a paralytic. Why you would put someone on a paralytic. Does that make sense? Okay. That's kind of the respiratory section in the shock, okay? Again, review that subject list. Make sure you can speak to all of those, okay? And then I will send out, like I said before, the blueprint, which can help divvy it up. It's pretty even, to be honest. It's pretty even between shock and respiratory, okay? Questions before we move on? No? Okay. All right, so we have neuro, the brain in trouble, okay? So, let's talk neuroassessment, okay? Let's talk about our neuroassessment. Actually, can I erase this? Is this okay if I erase all this stuff? You guys good? Took all of your pictures? I think I probably just erased this one. Okay, so look at mental status. What kinds of things are you assessing when you talk about mental status?
Are they oriented? Full of command.
Okay. So I'm talking about someone, so when you think about mental status, right, you are thinking about their level of consciousness, right? Their level of consciousness, right? So that is talking about how awake they are, their, if you will, arousability, okay? Now, something to make note of is that when we are talking about neuro, when we have someone that is neurologically impaired, the first sign that there is a neurological problem is going to be a change in your level of consciousness, okay? So let me say that again. When you have a neurological problem, okay, let's say something's getting worse, the first change you will see is that level of consciousness, okay? So that means that we talked about, right, that someone is going to be awake, alert, oriented. That change in level of consciousness is that you go in and they are maybe obtunded, okay? Maybe they're obtunded. So Now, we've talked about this, right? And we've talked about these words that we've thrown out. Can anybody tell me the difference between obtunded and stuporous? I know, I'm throwing out some forks out into the world, right? Some monkey wrenches. So again, you guys, if you don't understand what something means, do not use it. Okay? Do not use it. If I use something where you're like, I've never heard that word before, what does that mean? Please either look it up or ask, right? Because that's dangerous because you can misuse it, right? You can misuse it. So anybody want to tell me about obtunded? What does obtunded mean? Nobody wants to look it up? Try.
Refers to moderate reduction in alertness, where a person is slow to respond, has decreased interest in their surroundings, often responding only to tactile stimuli.
Okay, so did everyone hear what she said? Okay, so you have someone that's awake and alert, right? That's hopefully, well, you guys are probably more lethargic, but I'm awake and alert. I've had lots of coffee today, okay? So that's the highest, right? Awake and alert is the highest level of consciousness. Then below that, you have lethargic, where people, they might be a little bit more sleepy. It might be a little bit more difficult to hold a conversation. That's kind of where you guys are at, okay? And then you have, what's worse, obtunded or stuporous? Stuporous is worse. How you can remember that is that S comes after O in the alphabet. Okay, that's how I remember it. So obtunded, Alicia, read your definition again.
A moderate reduction in alertness, where a person is slow to respond and has decreased interest in their surroundings, often responding only to tactile stimuli but remaining confused or muddled.
Okay, so tactile stimuli, meaning that you have to go in and touch your patient. Okay, they're not maybe responding to voice right away. Okay, maybe they do speak, but what comes out is like mumblings, mumbled words. Okay, so again, level of consciousness, how awake they are. Okay, and then stuporous, right, is that the patient cannot speak. Okay, she cannot speak. She cannot speak. They only moan or maybe grimace. Okay, so if you think about it, right, I always think about like my charting. That's how I remember this, right? Where did my marker go? I just had it. Oh, it's right here. There's like 100 right here. Okay, so the first thing, right, are they alert? So we're talking about LOC, okay? Are they alert and awake? That's someone that you go in and you're like, hey, and they're like, hey, can I get some Jell-O? And you're like, okay, just give me a second, right? And then as we go down, and with the decrease of LOC, we have that they're lethargic. Okay? And then we have that they're obtunded. Then we have stuporous. Then at the very bottom, we have comatose. Okay? So as we go down, the lower degree of LOC, okay? The loss of consciousness, essentially, okay? So again, this is what you're evaluating. When you talk about mental status, you're looking at and you are picking where your patient lands, okay? You need to understand what these words mean and be able to speak to it, okay? Because this is part of your neuro assessment, okay? Please know that when someone is intubated, right, your neuro assessment is going to change, okay? It's going to change. In addition to the fact that if your patient is intubated, you could have sedation playing a factor in this, right? You could have sedation playing a factor in is where you are messing with someone's level of consciousness because they're on propofol. Okay, does that make sense? Okay. So again, mental status has to do with their level of consciousness. When we're talking about a neurological problem, that is the most sensitive indicator. The most sensitive indicator that something has changed and gotten worse, okay? And so with this, right, mental status, we also, someone said it earlier, we can also talk about orientation. Now, in orientation, what type of patient am I talking about when I'm talking about orientation? Are we talking about someone that's intubated or walkie-talkie? Walkie-talkie, right? When someone is intubated, I cannot ask them orientation questions, okay? It doesn't count, okay? It doesn't count. I've seen it countless times where they're like, yeah, they're oriented, and I'm like, how can you tell? They're not speaking to you, okay? They're not speaking to you. So orientation, you really need someone to be able to talk to you to understand if they're oriented, okay? Again, this is like block 1 nursing, right? Orientation, person, time, place, and situation. Not the president. Please don't ask that, right? Like, people need to get away from asking that, okay? Just the regular old questions is sufficient, okay? Now, GCS, okay? Everybody still have their markers? Okay, come right on the board what the GCS. GCS is Glasgow-Coma scale, right? This is part of your neuro assessment, okay? So what are the aspects? So there's 3 aspects that we're assessing. What are they? Eyes, verbal, and what? Motor. Perfect. Okay. You guys do eyes. What are the eyes? You guys back there do motor. Okay? Eyes, motor, verbal. Come write it on the board. You can erase that part.
We're doing verbal?
Erase the hypercapnia.
Is that any last Oh, yeah, I saw the comment section.
So for this one, which is verbal? Okay, so for this, A&O times 4, confused, inappropriate, what is that? There's something
Like not
else.
responding correctly.
Inappropriate words?
Yeah.
Okay. And then incomprehensible sounds, maybe?
Yeah. What they're trying to say, what they're trying to say.
Okay. So,
Non-responsive.
oftentimes, what'd you say?
The verbal would be non-responsive as well.
For which one?
Under verbal.
Verbal.
Non-responsive.
Okay.
Yeah.
And that, what is that? What is that score?
That would be,
Bump all the scores up to 1
would
Yeah.
be one.
on non-responsive.
Okay. So, this is one. Right. Okay.
Under motor, there's no non-testable, there would just be no response.
Actually, there is no test.
Well, non-testable.
Now
would
they're,
still be a
the
one.
charting is a little bit different. I know you're always supposed to do this, but sometimes they allow you to say non-testable. Like when someone's intubated, you can put non-testable for this, for verbal. I know it's different than what you've probably been encountered. If you chat GPT, this is not something that you'll be able to see, okay? But on the charting, they've changed the charting a little bit on Cerner, and I'm just letting you know you could see that.
So you'd
Okay.
have a GCS of 0?
Well, you would just say non-testable, you're not getting a true GCS, essentially. I mean, I know what you're saying, you should have a GCS of 3, right?
Yeah,
Yeah.
the lowest you can get is 3, so.
Right, so
non-testable is
sometimes
0.
you have on the charting now, not verbal, non-testable. I'm just letting you know that you could see that if you look at someone's chart, okay? For our purpose, we will continue with a GCS of 3, okay? Don't freak out, take a deep breath, everyone, okay? We got this. So, when you are assessing someone's GCS, oftentimes when people get report, especially when you have someone from EMS or someone from the ER, they may just give you a GCS number, okay? GCS number. If donor network calls you, okay? Donor network calls you, they're gonna ask you what your GCS is, okay? I'll be honest, I have to look at this. I have to look at this because I haven't memorized what the numbers are, okay? What I have memorized, okay, is that when someone has a lower GCS, okay, when someone has a lower GCS, that equates to me, okay, that their neurological status is impaired, okay, and oftentimes they're going to buy themselves an ET2, okay. When I think of a GCS less than 8, I know that I need to intubate them, okay. GCS less than 8 usually equates that I need to intubate them, that they are not able to protect their airway and they're going to buy themselves an ET2. Does that make sense? Okay, so let's look at eyes, okay? So obviously you get a better score for how neurologically intact you are, okay? So if you go in a room and you say to them, hey, Mr. Smith, and they spontaneously look at you with their eyes open, they can get themselves a 4, okay?
Wouldn't that be to speech?
Well, I mean, if their eyes are open already. If they're opening their eyes and like they hear you, and I'm sorry, I should have been more specific. If you walk in the room and they hear you and they're looking around, that's spontaneous, okay? You all hopefully are spontaneously having eye openings, okay? To speech would be if you enter the room and you have to say their name. Mr. Smith, open your eyes, okay? Then they might open their eyes, okay? People that were with me in the ICU, he had a GCS with the eyes of 3. I was able to say his name and he opened up his eyes, okay? Even though he heard us talking in there, he did not open up his eyes spontaneously. Does that make sense? Okay. So again, this becomes more stimuli, right? Because they don't open their eyes to speech, maybe you might have to elicit pain for them to open their eyes. Or they're gonna have no response, okay? This is the number you would get for eyes, okay? The total number, what I hope everyone is 15. I'm probably a 14 right now. But 15 is the best GCS that you can get. Okay, a 15 GCS tells me that my patient is awake, alert, oriented, following commands, doing everything neurologically normal. Does that make sense? The worst response, or the worst, is going to be a GCS of 3. That equates to someone being comatose. Okay, that equates to someone being comatose. So then you assess verbal. Okay, are they alert and oriented? Okay, maybe they're confused, they're going to get a 3. Okay, inappropriate words, right? Inappropriate words, unresponsive is 1. Okay, and then we go to the motor. So the best that they can get is obeys commands. Okay, again, it's going to change, right? How would I assess an intubated patient obeying commands? What? Can you? You can. You can.
Well, can you like move around the room and maybe ask them?
So when I say obeying commands, what does that mean? Okay, you're on the right track, but is blinking eyes a reflex?
Raise your arm.
Yes. So you're asking them to do some sort of fine motor activity, okay? Something that's not a reflex. People do this all the time where they say, squeeze my hand. If you put your finger in a baby's hand, what happens? They squeeze, right? It can be thought of as a reflex. I do not like that. I want to know that they're in there and they're able to obey commands, and so I do them something purposeful. Show me a thumbs up. They have to think about what their thumb is, and then they have to think about what that means, thumbs up, okay? Wiggling toes, okay? They have to think about their toes, and then they have to wiggle them. I will also change it up and say, wiggle the toes on your right foot. They have to think about, what is my right foot, what are my toes, okay? So something that is an action, right? They have to do an action, okay? Blinking does not count. Sometimes people say that they can nod appropriately. Be careful with that. Again, be careful with your assessment. I know you guys want a cookbook. You want A plus B equals C. But you have to be able to assess your patient and make it make sense. And what I mean by that is that if your patient's constantly doing this with their feet, spontaneously, you can't use that and say, Mr. Smith, wiggle your feet. Because they're already doing that, right? If they're going like this, non-purposefully, well, you can't say, oh, I just made myself dizzy. You can't say that they are shaking their head appropriately, right? So think about what you can ask your patient and make sure you're assessing, do they obey commands? The other facet to this is it consistent? Okay, we do assessments Q4 hours in the ICU, and that's something that I assess. Every single time I go in to do that assessment, I'm asking them, Mr. Smith, can you wiggle your toes? Show me a thumbs up, okay? Wiggle your toes on your left foot. Show me 2 fingers, okay? Show me 2 fingers on your left hand. Does that make sense? So yes, you can assess on an intubated patient whether or not they follow commands. Is it easier on a walkie-talkie? Absolutely. You say, where's your call light? How do you push it? That kind of a thing, okay? You'll run into people that are not intubated, that are walkie-talkies, that don't follow commands, right? Because neurologically something's wrong. Again, you're just assessing what is going on in neurological studies, okay? The next thing you want to assess is pain, okay? So when we're talking about localizing pain, okay, I need you to think about that the patient crosses their core. This is your core, right? They cross their core to take away whatever the stimulus is. So oftentimes we talk about how we do some nail bed pressure, okay, nail bed pressure. So I don't know if you've done it, you can do it on yourself right now if you like, but it really hurts. So like, be gentle with your patients. But what they're gonna do if they're localizing is they're going to reach across and try to take away whatever is causing that pain. That's localizing, okay? Withdraw is a little bit different. Again, it's less on the scale, okay? It means that neurologically they're not all there, or you're doing that from sedation, right? Again, it's a little bit different. We're talking about neurological problems, so we're gonna go with that theme. But I just need to understand that sometimes sedation can also cause issues. So withdraw to pain is they move away from it, just on this side, okay? Move away from it. Does that make sense? So localizing, you can also think about if I'm suctioning someone. If I'm suctioning someone, I cross my core to try to take away that yonker or to take away your hand from suctioning me or rip out my AT2. I'm crossing my core. That's what the localizing means, okay? Withdrawal from pain, again, you just have that simple movement where I move away from it. I do it on their toes, you see them kind of move away from it. That's withdrawing to pain. Now, abnormal flexion to pain and abnormal extension to pain, okay? You need to understand what these look like, okay? You need to understand what these look like. So when we talk about this, we are referring to posturing, okay? We are referring to posturing. So abnormal flexion is decorticate posturing, okay? Decorticate posturing. Let me say that again, you have to know this, okay? Decorticate posturing. How do you know? You need to look at pictures, okay? But decorticate is towards the core. So you'll see them posture. Oftentimes you're doing some sort of stimulus, some sort of, you're like touching them, maybe you're suctioning them, and they will what's called posture. So decorticate is towards the core, okay? And then what's worse, okay, is decerebrate, which is that extension, okay? Decerebrate is worse. So if you were to go in and assess your patient, and let's say that they were coughing, okay, they had some sort of stimulus, and you notice posturing, that would be bad. That would be very bad on the GCS scale. That would mean that we have some sort of significant neurological insult, okay? And then sometimes you have someone that's comatose where there's no response to pain whatsoever. They're flaccid, okay? They're flaccid. Does everyone understand what the GCS is? Does everyone understand how you get a score and what you do, okay? Please know the lower the score, the higher chance that the patient has some sort of neurological insult, okay? Does that make sense? Okay. Now, yes?
Are we gonna use the one from the book or for the class of home, or are you gonna provide us one if we need one?
Oh, are you talking about like on the test, give it to you? No, you gotta memorize that, bro.
No, but do we memorize the one from the book or which one we're going by? Or is it the same?
There's not one in your soft chalk, yeah?
Not in the soft shop, but in the actual book.
Yes, in the book. Go off the book one. Yes. However, like you, I don't know the GCS. Like, I'm not going to tell you, I'm not going to give you spontaneous, and they open their eyes spontaneously, and then they're confused, and then they localize to pain. I'm not going to do that, okay? I'm not going to give that to you on the test. What I want you to understand is that the patient is going to present differently, right, with somebody that has a neurological insult. So we'll talk about brain bleeds, for example. So where they fall on the GCS, that's how you're assessing someone neurologically. Does that make sense? Mm-hmm. So please don't get caught up. I don't want you to memorize it arbitrarily, right? But I just need you to understand that this is how you are assessing someone's neurological status. Okay, does that make sense? Okay, so we talk about motor function, okay? So we talked a little bit about motor function in regards to the GCS, but if you have someone that is obeying commands, something else that you want to assess is you want to make sure that they're moving all extremities, right? You want to assess, are they moving all extremities? And then also their strength. Yes, excellent, good job. Their strength, okay? So for example, where I come from, right? We score it. We score it with numbers. I know, you're like, oh my God, more numbers. What do I need to know about that? Essentially, you just need to understand, are they at full strength, or maybe are they weak, okay? So I usually say full strength is 5s, right? They move everything, 5s, they're totally intact, they're strong, okay? And then weak, if they're weak, I'm talking about, can they move against gravity? Okay, can they move against gravity, or are they flaccid? Okay, that's part of the motor function. Oftentimes, that is how you're assessing someone that's intubated. Okay, with a walkie-talkie, you may be able to assess their motor function and really take it a step further and assess their gait. Okay, assess how strong they are. Do they get up out of bed? Can they sit at the side of the bed? Do they get to a chair? Are they standby assessed? Okay, again, all has to do with neurological status. Now sensory, can they feel everything? right? Soft, sharp. You're assessing all of the limbs, right? What am I assessing when I look at their pupils? Okay, equal. What shape they are, round. And what?
Reactive to light.
Reacted to light. Are they getting smaller or bigger when you shine a light in them? They're constrict, which means they're getting smaller. Exactly. Okay. So when you shine that light on each pupil, you're looking to make sure that they constrict. Now, if I was standing under this light, okay, and I have like green, blue eyes, depending on what my makeup is, right? Do you think that if I'm looking like this, you're gonna get a great assessment? No. So again, make sure you're assessing properly. You probably should either have me move over there where it's a little bit darker or turn off the lights, okay? Again, you need to make sure you're getting an appropriate assessment and assessing your surroundings, okay? It's one of my pet peeves when I walk in and all the lights are on in the room and they're assessing the pupils and I'm like, how are you even really assessing that? Because instantly when you, again, on an intubated patient, their eyes may not be open. You may need to open them for them. And as soon as you expose that pupil to light, it's going to constrict. Okay, but because you were opening their eye at that point, you might have missed it. So the best thing is to turn off some lights directly above them and shine your flashlight to make sure that they are equally constricted, okay? Now again, if you have issues with the pupils, something is wrong, they're not constricted, they're dilated, they're unequal, that is telling you something is wrong with their brain, okay? Something is wrong with their brain. Now let's talk reflexes. We have a lot of reflexes, right? Oftentimes they're connected to cranial nerves. Do I want you to memorize the cranial nerves? No. But do I need you to understand what kind of reflexes you're assessing? Absolutely, okay? So one of the things I kind of mentioned is we talked a little bit about donor. Is anybody familiar with Donor Network and what they do here?
Yeah.
Hayden, what do they do?
They help with the basically procurement of donor organs.
Perfect. Okay, great. So real quick, two different routes that they can do, right? They can do something called when someone's brain dead, okay? They can procure their organs that way. Or they can do it what's called DCD, donation after cardiac death. Okay, we're gonna focus on brain dead because we're talking about neurological. If you have more questions later about DCD, happy to answer them. We just really don't have time to get into that, okay? So when you have someone that's brain dead, okay, donor or some sort of neurological insult, donor is going to be looking to see if they're brain dead because that makes them eligible for donation, okay? Who has donor status on their license? Okay, you don't have to raise your hand if you don't want to, but many of us do, okay? That means that you're a registered donor. You personally have made that choice. Your family is not involved in that as well, right? It's a personal choice. And so if you were to have some sort of massive, brain injury where you were brain dead, Donor Network would be involved and then your organs would be procured, okay? So when Donor Network comes in and asks you, they're gonna ask you about what your GCS is, okay? You have some sort of neurological insult, okay? We'll get into what kinds those are. And they're gonna ask you what your GCS is, okay? They're also gonna ask you about your reflexes. What kind of reflexes? Now when someone is brain dead, they are going to be what's called areflexive. They have zero reflexes, okay? Zero reflexes. So the reflexes that we're looking for are brainstem reflexes. Does anybody know what those are? Huh?
Like all the things that they do with like your ears and like the way that you turn your head.
So you're talking about like cold calorics, right? That would be something that they could assess, absolutely. But I'm talking about specific reflexes that the patient has. So something that we look for is, do they have a gag reflex? Okay. Do they have a corneals? Corneals is where you stick something in persons in their eyes and they react. Okay. Do they have, I said gag, do they have a cough reflex? And then also pupils. Do they have a pupillary response? Okay. So again, this would make it make sense, right? All of these things, all these million things represent a neuro assessment. Oftentimes your patients are gonna be great. They're gonna be neurologically intact and you can tick all of these things off. Other people, you're gonna go in and you're gonna be like, oh my God, everything is wrong with this patient. they have all of these issues with this neurological assessment. Okay? So why I spent so much time on this is I need you to understand that this is molding you. Okay? When you have someone that has been admitted with a neuro injury, okay, something has happened to their brain, you need to deep dive and do an assessment like this. Okay? And it's going to change whether someone's intubated or a walkie-talkie. Okay? Does that make sense? Questions about this? Okay. So let's talk a little bit about cerebral perfusion pressure. So the normal cerebral, this used to be a brain. I don't know why it's blocked out now. But the normal that you need to know this number, okay? Go ahead and put a star by it. You need to know this. Normal cerebral perfusion pressure is 60 to 100. Okay? Less than 50 is associated with ischemia and neuronal death. Okay? So we need cerebral perfusion to have brain function, right? And then less than 30 is certainly incompatible with life. So if you have someone that's less than 30, they're probably brain dead. They're areflexic. They have 0 reflexes. Okay? So what do you think are some factors that affect CPP? What do you think are some factors that affect it?
Position.
Okay, position could, sure, position. What do you mean by position? Tell me more.
Like, whether they're sitting up or lying flat to increase the brain pressure.
Okay. So like, you're talking more like along the lines of like venous drainage?
Yeah.
Okay, perfect, I love it, good. So positioning can affect it, what else?
Intracranial pressure.
Okay, excellent, so ICP, intracranial pressure, okay? We will talk about how you're gonna calculate this, okay? You need to know that for your test. That's the math part of your test when you get to trauma and burns and neuro. Okay, we'll talk about it, don't worry, we'll do some practice. But ICP can absolutely affect this. What about CO2? Could CO2 retention affect it?
Yes.
How so? Does CO2 constrict?
It vasodilates.
It's vasodilates, right? So if you have an increase in CO2, okay, it could vasodilate, which if you have a bleed, that could be a bad thing, right? So CO2, oxygen, all affect CPP, okay? And then mostly what we need to look for is ICP, intracranial pressure, right? Intracranial pressure is a huge thing that affects CPP. So here we are, intracranial pressure, right? You need to know these numbers as well. So we talked about CPP first, now ICP. Normal is 5 to 15, and then 15 to 20 is moderately high, and then an increase is greater than 20. You best do something about that, okay? Now, does anybody know what I'm talking about when we talk about Monroe-Kelly doctrine? I love talking about Monroe-Kelly doctrine. It's like one of my favorite things to talk about. Anybody know? No? Okay. So let's think about your skull as a box. Okay? So in your skull box, if you will, you have 3 different things. Okay? You have CSF, you have blood, and you have brain. Okay? 3 different components. Okay? Now, these work harmoniously together, okay? But please know that this is a box. And it's a skull box, meaning that it can't expand or contract. It's stuck there, okay? So anytime you have an alteration in one of these things, okay? So what I mean by, let's say that you have a brain tumor, okay? Brain tumor, and you have swelling. Okay, what's going to happen is that it's going to restrict this. So let's do this. In my box, okay, we have the compartments are going to change. Actually, sorry, let's just move this over a little bit. So swelling. Brain. And then this is CSF, and this is blood. Okay, So if we have in our box, our school box, that there's no real room for anything, there's 3 components that live harmoniously. If we have swelling that's pushing everything against each other and making this box way bigger than the other ones, this is going to increase my intracranial pressure, okay? Because I only have so much room for these 3 components, okay? Now it could be any of these. It could be that you have hydrocephalus and now there's too much CSF. It could be that you have some sort of bleed in your brain and you have too much blood in it and it's pushing on the brain and the CSF. Does that make sense? So when you have something wrong with your arm, for example, this is soft tissue, right? Everybody feel their arm. It's soft, right? That if you have swelling, it has room to expand. Does that make sense? Your skull is rock. Let's just think of it as rock. You have a rock box, okay? It can expand. So what happens is that somewhere you're gonna lose CSF and blood, but you can only do that to so much, okay? And then what's happening is that this is going to drive up your ICP. It's going to drive up your intracranial pressure, okay? Does that make sense? So you have to do something about it. You have to optimize this somehow, okay? You have to do something about it to either reduce the swelling, get rid of the blood, or drain the CSF to make it harmonious where they're all working together. Okay, does that make sense? Okay. So, what are some signs and symptoms of increased ICP?
Unequal.
Perfect, write it down. But you're totally right. Okay, let's talk about this. So, signs and symptoms of increased intracranial pressure. So something, right, is happening with your brain box, okay? Something is happening whether you have swelling, CSF is increased, or you have some sort of brain bleed. That the components have changed and your pressure to tolerate both of those things have been altered, okay? So the first and most sensitive indicator of a change in neurological status is what? What? LOC, exactly, a change in LOC, okay? So when I say that level of consciousness, right, it's going to have this, it's going to change this. So your patient was awake and alert and now they're obtunded, okay, or stuporous. So you have a change in your LOC. Again, you're gonna see that again. I don't know how more clear I can be. That's the most sensitive indicator, okay, of your neurological status. So an altered LOC, okay, is one of the cardinal signs of increased ICP, okay? Restless agitation, I see that in there, excellent, okay? Pupil responsiveness, what does that mean? Pupil responsiveness, you're right, but what does that mean? What did you say?
Isn't it like the ipsilateral
Okay,
dilation of pupils?
so
it's like
essentially you're looking and you're assessing what shape they are, how big they are, and when you're saying responsive, you mean responsive to light? Or no, what do you mean? Or what do you think?
I
they
don't
mean?
know what that is. I put on the ipsilateral, like that you would see that with their eyes sometimes at the pressure.
So what do you mean when you say
It's like the
ispidolateral? That's a hard name to say.
one-sided, like one pupil is the same, the other one is different.
Okay, excellent, good. So essentially what you're saying, right, I'm just making it a little bit more simplified, is you're saying that the pupils are unequal, right?
Yes.
Okay, perfect, yes, absolutely. So there's pupillary changes that are happening. You're saying that basically whatever the site of injury is the opposite or the same? Which one? The same.
Oh, well, no, it's the same side. As
The same side, exactly, perfect. So again, the take-home message is you have a pupillary change, right? They're either different sizes, okay? Maybe they're dilated, they don't constrict when you put light on them. Something has changed where your pupillary assessment is no longer normal, okay? You also have nausea and vomiting. I love that. Headache, that's one of the huge things, right? Restless and agitation. Seizures, right? Visual dysfunction, right? They're seeing double, right? Or maybe one eye you can't see at all, okay? Motor dysfunction. So again, we talk about our GCS over there where you see posturing. Posturing is definitely can be a sign of increased ICP, okay? Posturing, what's worse, decorticate or decerebrate? Decerebrate, exactly, good job, excellent. Please make sure you know what that looks like and what's worse, decorticate or decerebrate, okay? And then, I love that you guys mentioned this, Cushing's triad. Cushing's triad, if you see that, that is a medical emergency, okay? Something needs to happen very quickly to alleviate this Cushing's triad. So we have systolic hypertension with a widening pulse pressure, bradycardia, okay? And then altered respirations. Oftentimes it's lower respirations, okay? Altered respirations, lower respirations, okay? We'll talk a little bit more about that. I have a question that deals with that. Questions about what you will see with increased signs and symptoms. Yes, ma'am?
Do we have to go in depth, like, as far as early signs, symptoms, and late?
Tell me what you mean.
Like, the early with the LOC and, like, the late sign? I recall it being one of the late, like...
Cushing's triad, late?
Yeah.
Yep. You absolutely need to know that, for sure. Yes, thank you for differentiating that for me.
No.
Absolutely.
I
Yes.
think she means, in the test will be like, what are some early signs, and then you'll put all of the signs, but we need to identify which one's early and which one's late. 'Cause
Sure,
in
that
block
could be a
2
possibility.
In block 2, we had a differentiation for ICP.
Early and
Early and
late.
late signs.
Sure, you could know that. Yeah. Sure, I think that's good, right? I mean, really, the take-home message is I already said, right? The most earliest sign, the most sensitive indicator. When I say sensitive indicator, that means the earliest sign is that altered level of consciousness, right? You will see that on your test. I can guarantee that, okay? And then the latest sign is your Cushing's triad. I can guarantee you will see that on your test, okay? So again, am I gonna get caught up on headache versus nausea and vomiting and all that stuff? Absolutely not, okay? I just want you to know that the most sensitive indicator, the earliest sign is that change in level of consciousness, and then the latest is the Cushing's triad, okay? You guys tracking? Okay. I know, you guys are always, you're like, but what, I wanna know specifically, what is going to be the question on the test? Okay, so we just talked about the signs and symptoms. What are you going to do to lower your ICP? What are you going to do? I want non-invasive methods, and I also want invasive methods, and I want meds. What can you do to lower your ICP? I want all the strategies. Take some time, discuss it amongst your friends, but go ahead and write it down. Couple more minutes, guys. All right, let's talk about it. So let's do, oh, I love that you guys did non-invasive, invasive, perfect. Okay, so let's do non-invasive. So non-invasive, okay, so position changes. That seems like a very non-invasive thing, right? So when you have someone that is obstructing their venous outflow, okay, obstructing their venous outflow. Now what I mean by that is if their neck is turned in a weird position, okay? Their neck is turned, they are obstructing their venous outflow. So like right here, it's obstructing. It's not being able to go outside of my brain, right? That positioning can increase your ICP. So what would help, right, is midline positioning. You're looking straight ahead and you're sitting upright, okay? So positioning is very important, okay? Positioning is very important. That's a pretty non-invasive thing that you can do, okay? Another non-invasive thing is decrease the stimuli, okay? Decrease the stimuli. How would I maybe do that? What does that mean when I decrease the stimuli? Turn off the lights, yeah. Turn off the lights. You have 500 family members in the room and they're all talking at once. Okay, hopefully you don't have 500 family members in your room, but maybe you ask them to step out, right? So essentially what you're doing is you are having a quiet environment. So you're turning off the lights, you're making a quiet environment. A family member keeps touching the patient. They keep going like this, wake up, wake up, wake up, wake up. I don't know how many times I've seen that. Wake up, Sean, right? Okay? No, you need to sit down, okay? And you can explain to them in a kind, respectful manner and just say, right, that unfortunately with that stimulation, a verbal and tactile, you're touching them and yelling at them, that is increasing someone's ICP. Okay, that's increasing someone's ICP, so please sit down and be quiet. Or they need to leave. Okay, so non-invasive methods, right, is that we can make a quiet environment, right? Quiet environment, less stimuli, okay? Now, more other things that you can do, right, is making sure that you allow rest between patient care tasks, okay? So let's say you go in and turn them, okay? Turning them, stimulating like them could increase your ICP, okay? So maybe let them rest for a moment before you do oral care, okay? You just suctioned them. Let them rest, okay? Suctioning can definitely momentarily increase someone's ICP, okay? Let them rest before you do anything else. So allow periods of rest is very important, okay? So those are some non-invasive strategies. Now invasive, right? I understand that you might say mannitol is non-invasive, and again, I'm just trying to make it so it makes sense, but mannitol is the best drug to give. Okay, why is it the best drug? What is it going to help with? So it's an osmotic diuretic, right? So it's going to draw that free water from the brain, and you're going to pee it out, right? Hopefully. If you have renal failure, you might be in some trouble. What might need to happen when you're giving the mannitol if you have renal failure? Dialysis, exactly, okay? So you may need to look out for that, okay? So we're doing mannitol. Hopefully that's going to reduce the cerebral swelling, right? That could be driving up your ICP. Now, why did someone write 3%? What is 3% gonna do?
That's hypertonic solution.
It is hypertonic, you're absolutely right. Yep, totally. What is it gonna do?
Draw the fluid back into the cells.
Okay, so where are we hoping that it does that?
Up in the head.
In the brain, right? Absolutely. So we're going to drive my sodium up, okay, with the 3% and draw that extra fluid up. Okay, that's definitely something that you want to see when you're trying to lower someone's ICP, is you want to be monitoring sodiums, okay? Now remember, when we're talking about cardiac, I talked about mag, I talked about potassium a lot, I talked about calcium. When we talk about the brain, you best be noting sodiums. Sodiums is definitely something that you want to be careful of, okay? You do not want hyponatremia. You do not want a hyponatremia, okay? Sometimes you want hypernatremia that can help reduce that cerebral edema, okay? So we talked about decreasing the volume in the brain, right? We can do that with mannitol, we can do that with 3%, okay? We talked about positioning upright to facilitate that venous drainage, right? Again, we're looking at how to lower the ICPs, okay? And then you wanna make sure that you are monitoring acid-base balance. That's huge, okay? So you wanna make sure you're getting ABGs, because if someone is acidotic, that can cause dilation, right? We talked about that increase in CO2, and we don't want dilation of the cerebral vessels, right? We definitely do not want that. We don't want things getting bigger in there. We want to make them get small, okay? You might need to get rid of CSF. What could you use to get rid of CSF?
Cerebral shunt.
Yeah, that's what they heard say, give them shots.
Okay, sure, that's a long-term situation, but what would be something in this acute situation that they could put in at the bedside?
Lumbar puncture.
What?
Lumbar puncture.
Well, I mean, I feel like you could, but that's not something you could like keep in, right? That you could drain off continuously.
I had a patient this last week that had a spinal fluid drain
Okay,
in his lumbar every
like a
hour.
lumbar drain,
Yeah.
is what you're saying?
Lumbar drain. We
Okay.
have to drain 10 cc's every hour.
Okay, I'm not super familiar with lumbar drains, to be honest. I feel like that could help for sure. What I'm talking about specific, I think, so that, if I am conjecturing this, again, I'm totally being honest, I'm not very familiar with lumbar drains, but I feel like that would be spinal CSF. Is that what they maybe talked about, spinal CSF? Because I feel like your lumbar is right here, right? So that would be my guess, again, Totally not familiar, so I would have to check into that, to be totally honest.
Would it not all be connected considering it's all?
It would be all connected, but I think that if you have an acute change where you are looking and you have an acute change of ICP, you can't wait until it travels down your spinal column, right? And so I think I understand what you're saying, and it could be that. I'm just not familiar with lumbar drains, to be totally honest. But you would maybe want a drain coming from your brain.
Okay.
And what I'm talking about is the ventriculostomy, okay, the EVD drain.
I thought in some church it says like local puncture is not advised because it causes the herniation.
It can cause the herniation. So you don't want to do an LP because in this moment it could cause that. Yeah, because your brain can get sucked down in your spinal column, so maybe the lumbar drain wouldn't be a great thing. Again, I'd have to look at it, okay? Because the lumbar puncture is that initial puncture. I don't know how it works with the drain. For this purpose, okay, until I can research that, to be totally honest, I want you to understand that an EVD drain, a ventriculostomy drain, can help drain off the CSF, okay? That excess CSF. The other thing it could also drain, too, is blood. It can also drain blood. And the cool thing is that it's also going to give us a number. It's going to give us an ICP number, okay? So it's kind of like this great trifecta, if you will, of things, okay? So an EVD, that's gonna be able, the ventriculostomy is gonna be able to get rid of that CSF or maybe blood too, okay? And then I want you to make a note of this, okay? I want you to make a note of this, is that when you're lowering ICP, okay, you cannot stop the original insult. They have already had whatever neurological insult they've gotten, right? They've already got the brain bleed, got hit over the head with the hammer, right? It's got a TBI from a car accident, whatever that is. What our job is in lowering the ICP is to prevent secondary brain injury, okay? I'm gonna say that again. You want to prevent secondary brain injury, okay? This is all encompassing of how you're going to utilize these strategies to lower ICP, okay? So when you're talking about preventing secondary brain injury, you're making sure you're checking your pH. What lab is that when you check your pH? ABGs, yeah. Okay, so you're going to prevent that acidosis. So you're going to make sure that you're controlling the pH. You're making sure you have an airway. Why would an airway be important for this?
You can
Help.
the pH.
Okay.
On breathing.
Sure, absolutely. So that can also impact the pH, but also oxygenation, right? Doesn't your brain need oxygenation, right? Doesn't your brain need oxygenation? If you have really high ICP, really high intracranial pressure, could that impact your oxygenation? Could that impact your cerebral perfusion pressure? 100%, right? So you're going to have airway maintenance, control your pH, right? And then you're going to prevent that hypoxemia, right? Prevent that hypoxemia. Make sure that you're not hypoxic, okay? And then prevent hypotension. So essentially what you can think about is ABC, right? Make it so you remember it, ABC. So airway, control that pH. B, breathing, prevent that hypoxemia. And then C, circulation, prevent that hypotension. Why? Because we want to prevent that secondary brain injury. You cannot prevent what has already happened, okay? But we can prevent things from getting worse, right? Things from getting worse. We need to lower that ICP, okay? Could agitation and restlessness increase our ICP? What do you think? Yeah? Okay. So what kinds of meds could you give someone to help with that? If they're agitated or maybe they're in pain. What? Okay, so be careful with benzos. So benzos, oftentimes in neurological insult patients, if you will, we tend to stay away from benzos unless they're seizing, because someone can hold on to that for a while. It can alter their neurological exam, okay? Yes, they work when you have seizures, which your patient could have high risk for seizures if they have high ICP, right? So that would necessitate you to give them Versed, if you will. But to treat the pain, how about fentanyl? How about Dilaudid, right? So you want to make sure you're assessing for the agitation and the pain. What sedative is easy on, easy off? Propofol. So this might be someone that is needing propofol. Again, they have a definitive airway, but easy on, easy off, right? And so this would be someone that you might want to see that they have propofol, okay? And then, let's see, we talked about that. Okay, I think we talked about everything. Head of the bed, oxygen. Okay,
For the head of the bed,
yes,
do we want it at like a 30-degree or?
at least 30. At least 30, yep, at least 30. Okay, let's see. Okay. Okay, let's do this question. Thirty more seconds, guys, and we'll talk about it.
I'm trying.
Oh, you just do the windows button and the dot and the periods, and it opens up. The windows? Yeah, press the windows and then period.
All right, guys, which patient below is most at risk for increased intracranial pressure? Okay, so most at risk. Oftentimes you're looking at the people that have some sort of neurological insult, right? So a patient is experiencing severe hypotension. They're not necessarily, unless they have zero pressure for a really long time, they will not be at risk for increased intracranial pressure, okay? B, a patient is admitted with a TBI, right? So they already have something that's wrong with their brain, okay? They already have something that's wrong with their brain. So they are gonna be the one that's most at risk, okay? This is my MI, that's not great, but it has nothing to do with your brain, right? And then post-op from an eye surgery, sure, down the line, this could be something you need to look at. But again, we're looking at most at risk. And that's someone that comes in with a traumatic brain injury, okay? I really like this question, you guys. It's one of my favorites.
So that they say
But when you put it like that, yeah, it's like, yeah, and why are we doing suction?
Yeah, so,
Yeah.
to the end of these things.
Someone on la consistent.
What should I do? What should I?
Well, I missed the doorknob. Okay, guys, you wanna talk about it? Is this question hard?
Yeah, a little bit.
Okay.
The beginning.
The beginning, okay, I like this, let's talk about it. So a patient with increased ICP has the following vital signs, okay? So we have a blood pressure of 99/60 with a MAP of 68, okay? We have a heart rate of 65, we have a temp of 101.6, 14 respirators and oxygen saturation 95. Out of those vital signs, what one stands out to you that you're concerned about? The what? The temperature, okay, so they are febrile, they have a fever, right? ICP reading is 21, okay? So ICP is high, right? So is it moderately high or severely high? Severely, we need to do something about it, okay? So the ICP is high, 21, okay? So if we were to talk about, we haven't gotten to this equation, but I'm gonna just give you a hint, okay? So MAP minus ICP equals CPP. Okay, we're gonna practice that. So the MAP is 68, right?
Yep.
Minus ICP is 21. So MAP minus ICP equals a CPP. What's that number? 68 minus 21. 27. Okay. So if we were looking just straight out the gate, CPP, are we pleased with the number of 57? No. What's our goal of CPP? What's our goal of cerebral perfusion pressure?
60 to 100.
60 to 100, exactly. So we got to do something about this, right? So what would you do? Okay. So administer a PRN dose of a vasopressor.
Yep.
Okay. So a PRN dose. First of all, is there such thing as a PRN dose? Exactly. Okay. So right away, a PRN dose that doesn't exist. There's no PRN dose of a vasopressor. It's a continuous infusion. Okay. Now, let's say that we didn't even have that, right? So that didn't mark that as wrong. Okay. Is my MAP adequate? Do I have end organ perfusion? Okay. I do. I want my MAP always above 65. Okay. My problem that's driving down my CPP is what? Your ICP. It's 21. That's too high, right? So administer 2 liters of oxygen. What is that going to help me at this point? No. Okay. We know that my oxygenation, great, it's 95. Great, perfect. So that's not going to help. Okay. Performing suctioning. What is that going to do to my ICP? It's going to increase it. Also, we're going to see 30. Okay. So that's certainly not the answer. Okay. So I know this seems dumb, right? Remove extra blankets and give the patient a cool bath. Well, the room is 100 degrees and they have 50 blankets on. So we are driving their fever. Fever is one of the things that you will see that drives up someone's ICP, okay? So again, let's look at this, right? The problem is that we have ICP. How can we lower the ICP? Well, we need to treat the fever. How can I do that? The only answer I have available is remove the blankets and give the patient a cool bath. Okay, would I love to probably give some acetaminophen? Yes, absolutely. But I don't have that answer. This is the answer that I have. Okay, does everyone understand that? Do you understand how I figured that out?
Yeah.
Yes? You will see questions like this on your exam. This is a great example of what you will see. Okay? Okay.
Also, if you look at it, what's our normal and how do you fix it? This one I see. What gives you? No, I'm listening. I'm getting. He's quizzing now.
I feel like purchase CPP was in one. What is it in?
60 times.
60 times. Oh, this See?
A, drain and drain.
Oh, true. A lot of them. I need a table with all the ranges.
Alright, let's talk about it. A patient has a ventriculostomy. Which finding would you immediately report to the doctor? A temp of 98.4.
Nah.
Are you concerned? Nope. CPP of 70. You concerned? Nope. That's good, right? We want a CPP of 70. That's fabulous. ICP of 24. It's high, right? It's high. You should definitely contact them and let them know that your ICP is 24. And then PaCO2 of 35. Concern? High, low, or normal? Normal. Perfect. Good job. I also really like this question. This is a very good question, okay?
Ooh, I don't know.
So which ones of those expresses that's now?
We just saw.
Yeah, we just saw it. It was in this, within a shop.
Oh, good. You guys are doing so great. Okay, so which patient below with ICP is experiencing Cushing's triad? Okay, so we first and foremost, we're looking for bradycardia, right? We're looking for bradycardia, so you can get rid of a couple things, right? So a heart rate of 110, not bradycardic, so we can say right away that's not the answer, okay? The second one, heart rate of 80, is that bradycardia? No. Sinus rhythm, probably, so we can get rid of that. So now we have the last two, okay? So we have a heart rate of 50 and a heart rate of 49, both bradycardic, right? Now we have respirators of 8 and 12. What's lower? 8, okay. So again, both are kind of low, but 8's lower, okay? Now let's take it home, okay? So when you have hypertension with a widening, or systolic with widening pulse pressure, high systolic with widening pulse pressure, okay? So what is pulse pressure? How can you determine what pulse pressure is? Systolic minus diastolic, right? Okay. So right away we have hypertension, right? We have 200. But to identify that widening pulse pressure, right? Because sometimes you need to make sure you're identifying that we're progressing to Cushing's triad, right? So 200 minus 60, what is my pulse pressure? 140. Okay, what's my pulse pressure with 80 over 4, or 80 minus 40? Excuse me. 40. Okay, so we have all of them, right? We have bradycardia, we have altered respirations, lowered respirations, high systolic with a widening pulse pressure. Okay, so that is our Cushing's triad. Those are the vital signs you will look for. You must know that for your test. Okay, please familiarize yourself with that. Let's do this last one and then we'll call it quits.
to get straightened up. Yeah. So, but I mean, and they have the cortical, like the arm,
Oh, no,
and the cerebus, it's like a zombie. No me acuerdo quién dijo eso. Yeah.
Okay, guys, during this test with a patient with increased ICP, you note that the patient's arms are extended straight out and toes pointed downward. So, for the exam, you need to know description of words as well as pictures, okay? So, pointed downward, you will document as what? What do we think it is? Decerebit, yes. What's worse, decorticate or decerebit? Decerebit, excellent, good job. Okay, in these last few moments of time, does anybody have any questions about your exam? Okay, so remember, it's respiratory and shock, okay? I can't remember, I think it's 60 something questions, I think it's like 65 or 67. On your syllabus, it would have the number, okay? Let's see, what else? I work, so Professor Pollitt will be proctoring it, okay? I will have your scores done in a timely fashion, okay? Remember, yay for us, yay for everyone, SATAs, partial points. You will see more SATAs on this exam, okay? So mentally prepare yourself for that. Make sure you go over ARDS, you guys. Make sure you go over that. Make sure you go over respiratory failure, okay? Make sure you're going over the shocks. Understand how to differentiate them. Signs and symptoms, what you do for them, okay? Spend some time on sepsis. Yes, you need to know all of them, but spend some time on sepsis and septic shock, okay? Look at that subject guide. Utilize that for your studying. For respiratory, you do not need to know about thoracotomies. You do not need to know about lung cancer. Maybe in your life, in NCLEX you might, but for my test, you don't have to worry about that, okay? Ventilator settings, do not get caught up on this, okay? Don't spend a million hours trying to understand this if you don't get it, okay? Why we talked about this is because it connects with what you're going to see with hypoxemic respiratory and hypercapnic and the settings you can manipulate, okay? And what you need to do to treat refractory hypoxemia, okay? Any other questions? You will have math. Make sure you understand how to do dosage calculations, yes.
Is lobectomy gonna be in it, or?
Lobectomy, no.
This exam is not neuro.
Nope. Next exam is neuro trauma and burns. Okay. Okay, this is just respiratory and shock. Are you guys all in shock? You look like you're a little shell shock. Okay. Please reach out if you have any questions. Okay. If you're studying and you don't understand something, please reach out. I'm always available during email. We can figure out a time to meet if that will be helpful to you too. Okay. But please reach out. Utilize the practice questions. Utilize them, okay? Look at your soft chalk. If you need more information, utilize your textbook, okay? Listen to the lecture recordings, okay? Sometimes hearing it again is very, very helpful. You don't have to listen to the whole thing, but maybe you think that, septic shock was really hard and I need to listen to that. Spend some time with that, okay? You have Scarlett's recording, and you also, yay for her, thank you everyone, right? Thank you to her, yes. And then you also have my previous lecture recording a couple years ago, okay? Both are